Perfect. Thank you so much for the opportunity for allowing me to share about the Kaiser Permanente Hawaii experience with long COVID. So we started this clinic definitely in October of 2022. I have no financial disclosures. I'm going to go over some of the objectives of today's presentation, the background of why we opened this clinic, the past clinic data so far, some cases, and the evidence for management that we used at the benefit of COVID-19 vaccinations, support groups, and learnings. So long COVID is definitely a patient-taught disease to us. It was patients who were telling us about these symptoms after having the COVID infection. And it is their symptoms, their experiences through which we've learned about the long COVID condition. So this is a picture from Kate Mayo, who's a person who did this art. And she describes sometimes the grief of a life changed by long COVID is overwhelming, like drowning in your own tears as doctors dismiss you, people stop inviting you, the world moves on without considering you. And this is at their lowest point, and you can see this art at the Canadian Symposium on Long COVID. It's just an expression of, we're dealing with this for 5 years, going on to the 6th year next year. So CDC, what does Centers of Disease Control say about long COVID? Well, they say that it is a condition, it's an infection associated with a chronic condition that affects one or more organ systems, and that primary care physicians can actually manage long COVID through patient-centered approaches. Objective laboratory and imaging findings should not be used as the only measure or assessment of a patient's well-being, and that healthcare providers should set achievable patient care goals through shared decision-making approach and approach treatment by focusing on specific symptoms or conditions. And that healthcare providers should help patients with long COVID by validating their symptoms and connecting them to additional care services, supports as appropriate. And providers should promote COVID vaccines as a means of preventing long COVID. So we, of course, we're seeing patients in our primary care settings. Even as specialists, we were seeing patients come in, and you sort of thought that the symptoms that they were experiencing was from COVID infection, but there wasn't a specific time allocated to evaluate these patients comprehensively, and patients were feeling like their concerns were not being heard. They were definitely having these symptoms, but people weren't associating it perhaps with COVID. So we opened this clinic in 2022 as a space for providers, specialists, PCPs, anybody, ER doctors, urgent care providers, to refer patients for our clinic for comprehensive evaluation and management of the post-COVID condition. If they had a suspicion that this patient had a COVID condition, post-COVID condition, they could just refer it. They don't have to do any additional testing for it. And patients who are 18 and older were evaluated by myself, like an internist, and patients younger than 18 were evaluated by a pediatric physician, a rheumatologist actually. And that we would actually tie in the management of chronic comorbid conditions such as sleep apnea, diabetes, hypertension, congestive heart failure, anxiety, depression, and others, in also the management of the post-COVID condition, because you can't really manage post-COVID alone when patient has other comorbidities. You have to manage their other inflammatory and chronic diseases. We use the process of e-PASC referral, and that would be converted to a face-to-face visit, or tele or a video visit. And because Kaiser, we're a smaller group, we actually can place referrals within our group fairly easily. We could do chart reviews. So it's still a multidisciplinary process. So 95% of patients who had this past virtual referral place had either a virtual visit or an in-person visit at Kaiser. And we wanted to discuss achievable goals with patients, because we wanted to see patients as an individual, not as a disease alone, but what mattered to them most and what was their immediate achievable goal. So we had a longer time space to evaluate patients with the post-COVID condition. This is our regional guidance from Kaiser. Southern California guidance. This is the one from Kaiser, where we have specialists for specific condition. And this goes off the CDC recommendations as well. For example, for fatigue, the basic labs that you would order, the basic evaluation that you would do, refer patients to physical therapy, what sorts of medications perhaps would complicate their picture, such as benzodiazepines, all of that, and when to refer to a specialist. So each of these conditions, or the most common post-COVID condition, was actually evaluated by a specialist, and they would come up with recommendations of labs or referral process to specialists. Samples of this is from KP Regional from Southern California for cough, dyspnea, abnormal chest x-ray, what to do. So this is like a basic evaluation that they would expect a PCP or even urgent care, any provider that the patient is first coming into contact with, and expressing the concern of a post-COVID condition. And these are periodically updated. So we were actually looking at data on our vaccination rates from 2020 to July 2025. And we looked at data of 350,000 KP members, and we were seeing of what they identified themselves to be race, ethnicity. And we noticed that our Asian population had the highest vaccination rates at 76%. Followed by actually Filipino, which was pretty good. They at least got the first vaccination, followed by the booster. And then sadly, Native Hawaiian Pacific Islander here, we're at 54%. And then followed by, we saw Caucasians around like 65%. And Black African American patients were vaccinated about 54% as well. So this is something to improve upon. We're definitely trying to approach our Native Hawaiian Pacific Islander population and improve the vaccination rates there. That there are definitely limitations about vaccine myths and some reservation about possible complications from vaccines that prevent them from getting the vaccinations timely. And then we were looking at patients. We've had about 450 so referrals come through the PASS clinic, just trying to see what disease comorbidities are we seeing with long COVID, and about 20% of our patients did have diabetes, and 52% had a BMI greater than 30%, 59% complained of dyspnea of some sort, and of course, this is expected that as we see that the biggest symptom that post-COVID patients complain about is fatigue. So 86.67% complained of fatigue. And then at the bottom here in this chart, we see fatigue, dyspnea, BMI. Here's arthritis, tachycardia, cognitive deficits, depression. When patients come into our PASS clinic, we did initially give them a post-COVID survey that included, basic ID information and also what symptoms they are experiencing based upon organ systems and the severity of those symptoms at the time that they are presenting. We also included the post-COVID functional survey by Dr. Fredlikus Klock. And so the post-COVID functional status scale is actually unique because it includes the depression as a possible limiting factor in their functional ability. And this came out in early 2020. We have some initial PASS clinic labs depending upon what the patient presents with, and this is part of the CDC evaluation as well. Of course, the basic labs that you would see, as well as the CRP, we did include interleukin 6 and interleukin beta 1. We do check an AM cortisol and follow that up with a cosyntropin stim test if we needed. Instead of the D dimer, we're checking the fibrinogen activity level. So going forward with the cases, wanted to discuss 4 cases. The first one is actually a patient, 68-year-old female with history of fibromyalgia since 1993, had 2 COVID infections, one in 2023, second one in 2024. And shortly after the second episode, she started to develop paroxysmal SVTs and frequent PVCs. She reports struggling with brain fog, difficulty multitasking. She used to do really well managing her husband's business. She endorses severe fatigue, which is new to her. She needs to take an afternoon nap. And she also reports paresthesias and worsening fibromyalgia pains. She's currently managed with bupropion, pregabalin, meloxicam. She's also on metoprolol, 12.5 milligrams, a low dose to manage her paroxysmal SVTs and PVCs. She takes magnesium, glucosamine, garlic, fish oil, and coenzyme Q10. She's also on a low dose hormone replacement therapy with a transdermal estrogen and oral progesterone. Our main concern is definitely the brain fog, the word finding difficulties, losing train of thought as she is, telling something to someone, easily distracted and not being able to finish tasks, and fatigue, this new afternoon naps. She has no alcohol history, no smoking, no illicit drugs, no significant family history of dementia. And she says she can only do one task and she gets really exhausted after that. Her Montreal Cognitive Assessment was normal. She goes for daily walks, maybe walks for a mile. And all of her lab work was normal, brain imaging was normal. We did definitely discuss, we talk about pacing. That's a big thing, planning, prioritizing ahead of time, and also making sure that you delete any activities that are not important, delegating them and deferring activities. In addition, I did discuss with her about trialing low-dose naltrexone for her, and started her off 1 milligram and then gradually increased her to 3 milligrams. And I go up like in 2 weeks, so like 1 milligram for 2 weeks. And then after that, they can go up to 2, maybe 2.5 after 2 weeks, and so on and so forth. She did pretty well actually with this. She saw great improvement in fatigue and brain fog. She was able to return to 90% back to her baseline. She's actively gardening, helping with her husband's business. I wish that every single case was this successful, and we know that is not the case. So when we're looking at how can we manage our patients, and fatigue happens to be the number one symptom, and what else can we support them with? And it's all symptomatic management. So this study here is like a study that was a survey. It's an online platform survey known as Treat Me Survey that was done on 3,925 patients, of which 2,125 were suffering from chronic fatigue syndrome, myalgic encephalomyelitis, and then 1,800 had long COVID. And they examined something like 150 supplements, OTC meds, prescription, non-pharmacological interventions to see which might provide them with benefit in chronic fatigue and with long COVID. And as you know, there is a great overlap of both. Of course, chronic fatigue can be present for years, like 6 to 8 years or so. That was the average of the symptoms. And for long COVID, these patients were about 2 to 3 years or so. And essentially what they found, and you can see what they did was they tried to see benefit, 20 or more surveys of each treatment group, and they tried to compare this top group with the not liposomal vitamin C supplementation group that took this supplement, and that acted like their placebo or their comparison. And they essentially looked for something that we call as the net assessment score of the benefit. And so we see right here, the darker orange is like much better, and then it's moderately better, and then slightly better, and then unchanged, unsure, or worse. And you can see the darker blues are like much worse. The greatest benefit was really the pacing for chronic myalgic encephalomyelitis or chronic fatigue syndrome, followed by fluids and electrolytes, compression stockings, antihistamines, and you'll see low-dose naltrexone. They also looked into ivabradine, beta blockers, and you can see here that the benefit, again, like 47, 49%. And over here, you also see ADHD stimulants, which we do use in the PAS clinic. We do prescribe patients with methylphenidates, even modafinil in certain situations if they have trouble working. They compared it to antivirals, Raviroc, coenzyme Q10, vagal stimulation, palmitoyl and curcumin. So somewhat beneficial, but not every patient has that sort of a benefit. But this was one of our patients that did benefit from it. Any questions so far, or should I keep going? Do we see anything? Sorry, I can't see.
Oh, so I don't see any chat, but I'll let people. But how do you use TreatMe to decide on what to try on your clients? Do you have like a way of, is there a go-to drug or medication, or do you try to tailor it to a patient, or
Yeah,
or
I
what?
think
Yeah.
that's a great question. I always say, obviously, this lady, she actually was somebody that had palpitations, and with low dose naltrexone, we always have to be careful if that would cause her to have palpitations or cause anxiety or something else. If patients have anxiety or palpitations, I'm a little bit less reluctant to give that. Or if they are on opioids, for example, naltrexone would counteract against that. So you can't actually give them low dose naltrexone. So definitely pacing is number one. I always discuss with the patient, you plan ahead, you prioritize what you need to do. That's important. Utilizing apps like Visible or something that's free that you can download and kind of monitor your activity, fluids, electrolytes. And then if they really feel like I need to manage, like in this case, this lady was like, I really need to manage my husband's business. I'm not functional. I am managing his accounts. And so we have to give her something. She's not somebody that I would jump to give her stimulant. So that's how we result in this. It's a shared decision making. And I always tell them it's not proven, it's not FDA approved. This is something that naturopaths use. It's not going to be covered by your insurance, probably be around $30 for a month's supply. And if you don't like it, you can always stop it, especially in the low doses. Yeah, hopefully that answered. Yeah. And just that, the LND, the way that it works is that it blocks the opioid receptors. And I always tell them, the effect might be 2 to 6 hours later, you might see some benefit, and then you might accomplish one task per day, perhaps. And that might be enough for most patients to get by. But in addition, you still have to exercise, you still have to do self-care things, not depend on the medication alone. So this is a second case of a 66-year-old female who was seen for follow-up for COVID-19. And her big concern was loss of taste and smell since April of 2022 COVID infection. And she was referred to our clinic after 6 months of loss of taste and smell. She was unable to taste sweets, salty foods. She had no idea how much salt to put in her food. She was often adding excessive spices to taste her food, much to the complaints of her family. The foods that she used to love, like cheese, are tasteless for her, and everything had some odd texture or tasted grainy. She also had phantom smells of smelling smoke or oil. She was evaluated by ENT. They couldn't find a cause for her loss of smell or taste. They advised zinc and B12 supplementation. And then she had MRI of the brain that showed no evidence of sinus disease, a normal brain parenchyma. Labs were normal. She herself, and as we know, a lot of our patients are frustrated and they will look at novel therapies to help themselves. So she herself researched about stellate ganglion block and wanted this treatment for her smell taste disorder. And of course, we were like, okay, well, that is an invasive procedure. Can we try something else, such as ultramicronized palmitoethylenamide with luteolin and olfactory training? And we have olfactory training that we give for our patients, and that's essentially choosing 4 pleasant smells and smelling each scent for 10 seconds, very close to the nose, twice a day for 12 weeks while taking the supplement. So she did the olfactory training with the PEA luteolin, and then she didn't see much benefit, and she researched about it, and she still wanted to go with the stellate ganglion blocks bilaterally. We had shared decision making about that. We told her this is not an FDA approved procedure for this, but she still wanted to go for it. And we asked the IR department if they could do it. And they said yes. And so she got it and she actually saw a great benefit from it. So where is this coming from? So there's such limited data on all of this that we have to kind of grapple. So what is this supplement, PEA luteolin? So it's a neuroinflammatory supplement, generally well tolerated. There's not much adverse events really reported. First study, so these two are from Italy, and the first author is the same. And so this first study, they looked at 202 patients who had olfactory dysfunction. And they tried olfactory training with PEA luteolin, in just 1 time a day, or with PEA luteolin and olfactory training. And essentially what this showed, it's a small sample size. What they did see is that the patients who had placebo, which is nothing, and olfactory training did not really recover as well as patients who had PA luteolin with olfactory training. And they noticed that they actually had better smell on the sniff and sticks odor identification, that they actually recovered pretty well at 90 days in comparison to PEA alone 1 time a day or olfactory training and placebo alone. The same here, they looked at 130 patients. And again, these are all adult studies. Again, it showed that patients who just received olfactory training did not recover as well as the control group versus the treatment group, that the treatment group actually saw a greater benefit with olfactory training. However, with parasomnia, they did not see much benefit. So olfactory dysfunction in terms of not being able to smell things improved. But when we say parosmia, which is like where you actually have altered smell to a stimuli, that did not improve very much. So parosmia is altered smell to something that was, smelling appropriately before. They did not see a benefit in that. So what is the cervical sympathetic block? This is something that is fairly new. And generally, the basis is that in long COVID, patients suffer from a dysregulation of the sympathetic nervous system. That's our nervous system that's associated with the fight or flight response, that controls our heart rate, and enhances cardiac contractility, vasoconstriction. The parasympathetic nervous system governs the rest, digest kind of thing. And so there is a hypothesis in long COVID, and some studies have shown that patients in long COVID typically have this dysregulatory sympathetic nervous system response that is responsible for the autonomic dysfunction, the immune dysregulation, and that perhaps blocking that, sort of resetting that system, would help them in the long COVID. So that's been studied with small studies with loss of smell, loss of taste, and also with global symptoms such as fatigue, brain fog, the autonomic dysfunction that you see with POTS and others. So essentially, there's many ways that you could do that cervical sympathetic blocks, and all of these chains. So people can receive a block of the superior cervical ganglion, middle cervical ganglion, or stellate ganglion. And most people approach this one, and patients can have unilateral or bilateral blocks with different types of drugs. So this came into light recently. It's been studied in regional complex pain disorders, sometimes in autonomic dysfunctions, but this came to light in long COVID. So this is a scoping review on 16 studies involving 224 patients, following what they looked at as the preferred reporting items of systemic review and meta-analysis. And what they were looking at is patients who suffered from brain fog, fatigue, autonomic symptoms, reduced, heart rate response, or orthostatic intolerance. And they also looked at whether cervical sympathetic blocks could help patients with cognitive impairment and all of that. And they essentially found that these 7, they looked at, again, small sample sizes, as you can see, 41, 47, 27, 17. There was some benefit with brain fog and fatigue, possibly, in some of the blocks. In terms of smell disorders, it didn't really make a huge difference. Parosmias did not improve significantly in certain groups. Again, really inconclusive evidence, not FDA proven. And when we presented this to our patient, we also said, listen, we don't know, you could have complications from this procedure. And she insisted that she felt that it was worth her quality of life to go forth with it. And thankfully she did okay. We've tried it in all of like probably 7 people. I got to say only 3 people really benefited from it. And most of them were for smell taste disorders after having comprehensive evaluation from ENT. We didn't feel so bold for people who had fatigue or brain fog to subject them to this. There's a temporary Horner syndrome that people do experience. You know, again, that's reversible, and that's considered the success of this procedure itself. They could have like a droopy eyes and miosis and reduced sweating on the site that they would do the procedure. It's sort of controversial. We only tried it in 7 patients, but that's something that's out there. So this is another study that looked at stellate ganglion block for COVID-induced olfactory dysfunction. This was a study from Washington University, and it was done on 80% of women who were 100% Caucasian, and they had olfactory dysfunction present for 12 months post a COVID infection, and they underwent bilateral stellate ganglion blocks. And the primary outcome that they looked at was a 7-point clinical global impression scale of smell improvement at 1 month. And they also looked at something called clinical global impression improvement and the olfactory disorder dysfunction outcome rating. Again, really small sample size, 20 patients, mostly female, and they noted that there was an improvement from their olfactory dysfunction. This was visit 1 was like before the stellate ganglions. Then there was visit 2, which was 1 week post bilateral stellate ganglion block. And then visit 3 was 1 month post. And they did find that about, 45% improvement in parosmia and 50% showed there was slight improvement in their odor scale. So again, limited studies, controversial. So 3rd case here, anybody have any more questions on this, or should I proceed?
I would proceed.
Okay. This is a female patient who was actually hospitalized. She was 59-year-old female with asthma, hypertension, prediabetes, obesity. She was hospitalized with severe respiratory failure from COVID pneumonia from December 31st, 2021 to February 2nd, 2022. So her risk factors were essentially hypertension and BMI. She was treated with remdesivir, dexamethasone, tocilizumab, and I can't pronounce this word, baricitinib, and oxygen support, but was not intubated. She was noted to have adrenal insufficiency during her critical hospitalization. And she was discharged initially on Soluporta, but we don't know what happened. And then she was transitioned to midodrine. She was not on any such meds. So she saw me like a year later. She was just on hypertension meds. And she was on chronic nasal cannula oxygen since her hospitalization. She used about 2 to 3 liters. And she just came in, and her main complaint was severe fatigue. And she felt like she was working full-time before as an administrator at Pearl Harbor. And she used to swim regularly. She used to go on regular walks, but now she can only walk a few blocks before getting very exhausted and tired. And since her COVID hospitalization, she was forced to retire. Even doing basic stuff around the house was very challenging for the patient. She also had brain fog. She needed to take several naps throughout the day and not feeling refreshed. She was also using her CPAP and oxygen at night for her sleep apnea. So part of our long COVID, when patients complain about fatigue, they obviously check for sleep apnea and all of that, but we also check the baseline cortisol. You can see here in the morning, around 8 o'clock, her initial cortisol was pretty low. And then we actually did the cosintropin stim test and we're looking for a rise of 18, which we did not see. So she did have adrenal insufficiency. And as you can see on the 18th of May, when we did her ACTH, was abnormally normal. Like you're supposed to see an elevated ACTH, wasn't. So she's noted to have adrenal insufficiency. They think it's a central adrenal insufficiency. And we automatically referred her to endocrine and they gave her hydrocortisone. She did remarkably well. She travels to Vegas now. She even gives rides to other people. Her MRI of the brain was normal. So just the background is that we should keep in mind that we should be testing patients for adrenal insufficiency. Her risk factor could be high-dose steroids, which were used during her acute hospitalization for COVID infection, but also that we do see adrenal insufficiency even in patients who did not have such a severe illness and were not subjected to steroids. We do have about 3% of cases that have had adrenal insufficiency, and half of those were not hospitalized with COVID. So that's something to keep in mind when patients are complaining about fatigue. This is a study in northern India where they actually looked at patients, 302 patients or so who were hospitalized with COVID. They were hospitalizing everyone at that time for whatever reason. And they followed them for about 24 months to see who developed adrenal insufficiency. And initially, they had about 232 patients who did have some hypothalamic adrenal axis deficiency, and adrenal insufficiency was noted in 33. They subsequently also followed up with those patients, and they noticed about 14% or so ended up with adrenal insufficiency that was prolonged. And they felt that it was not all of them, more than half of them did not have chronic exposure to steroids. So that's something to keep in mind. And also they noted that at 24 months, that patients can actually recover from this central adrenal insufficiency and may not need prolonged course of steroids. That is a developing subject. And endocrine has noticed that a couple of our patients not needing hydrocortisone as much anymore. So that's something to keep in mind. And this could be from viral tropism to pituitary adrenal axis, autoimmune inflammation that could potentially affect the hypothalamic pituitary axis, corticosteroid insufficiency that perhaps is prolonged despite the improvement of the acute illness. But that is something to keep in mind. Any questions about that? No. Okay. It's the final case. This is a 65-year-old female with hypothyroidism, hyperlipidemia, cervical and spinal stenosis, contracted COVID infection for the first time in April of 2023. Since then, developed severe fatigue, neuropathic pain, severe tremors preventing her from walking, gait unsteadiness with falls, dizziness without vertigo. In addition, she also reports severe brain fog, heaviness in her legs, and shortness of breath. Neurology actually referred the patient to us because they couldn't figure out why she was having so many tremors, and they couldn't figure out her neuropathic pain. She was having progressively worsening ataxia, shaking, and tremors. Her EMG was normal. MRI just showed this multi-level degenerative joint disease and severe facet arthropathy. Nothing that fully could explain her tremors, really. And she was experiencing some low back pain and radiation down her legs. So they gave her duloxetine, gabapentin. She's on some thyroid medication, meloxicam, and muscle relaxants, and pantoprazole, estradiol cream, and some inhalers, multivitamin, vitamin D. Labs only showed slightly low vitamin D, nothing else really significant. She gets very dizzy, so she had some autonomic dysfunction. She gets very dizzy with long walks, no chest pain, and Baina was helping her. So this was a severe case, and she was, fairly young. I would say 65 is still relatively young, and we wanted to help her. Um, and she was already on a bunch of supplements that she tried. So I discussed with her about the Stop Task trial, which was on Paxlovid for 15 days. I told her that it's not FDA approved for this post-COVID condition. We can try it on her because her symptoms were so severe. She couldn't even drive to our clinic, and somebody was bringing her. So we said, okay, we can try it. We can monitor your liver labs, know that there was no significant harms, but we don't know if the benefits are going to be significant. And we only tried this in 7 people. So it's not like this is a therapy that we would offer, and it's really not proven. It's based on really small sample size. She said she wanted to try it, and she actually did remarkably well. We checked her labs initially, and then we checked them every week while she was on Paxlovid just to make sure at the completion of 5-day segments of Paxlovid. That's how we gave it to her. Nilmetrelvir with ritonavir, and she actually improved significantly. No more tremors, no more shaking. Her dizziness, brain fog, and fatigue resolved, and she is actually exercising for 30 minutes now, walking even 2 miles a day, feels 90% better. Again, this is of the 7 people that we tried, 4 people improved a little bit, but the other 3 made no difference. And some people definitely had metallic taste and didn't see that it was worthwhile. So this is not something that we would promote. And it's something that's used as a last resort. And I did try it in severe cases. Thankfully for this patient, it worked for her. This is the popular trial, the Stop Fast trial that done by by Stanford University. And they studied 155 patients with moderate to severe past symptoms lasting 3 months or longer. And the time period that they studied these patients was November 2022 to September 2023. And they were randomized to receive either nirmatrelvir and ritonavir or placebo and ritonavir. And they gave them that for 15 days and followed up with them for up to 15 weeks. And the primary outcome that they looked at was 6 core past symptoms, such as fatigue, brain fog, body aches, cardiovascular symptoms, GI symptoms, so on and so forth, shortness of breath. And what they found was there was no statistical difference at 10 weeks for either the treatment group or the placebo group just with ritonavir. There were no significant harms, but it was not necessarily beneficial. And as you can see, the top symptom is very severe, the dark, then moderate severe, then mild, then, not much, but there was no significant difference in these groups. It was exciting when it started out because we were hoping that this would be the answer, but this does not seem to be the answer for our long COVID patients who are struggling. But something to keep in mind and closely follow up with those who are willing to try it on. Any questions again on the chat on this? It was a controversial topic. No. Okay. So here in Kaiser, we promote COVID vaccination. I think we take vaccines for granted, but there is good evidence now that actually COVID vaccination and boosting really reduces the long COVID risk and the symptom persistence. And along with COVID vaccination, you might also want to promote vaccination for influenza and other viruses because every subsequent viral infection potentiates the inflammatory process of long COVID. This is a study it's a VA study that looked at 441,583 veterans. And what they were looking at was cumulative incidence of the post-COVID condition in the pre-Delta, Delta, and the Omicron eras. And they wanted to compare it to our controls, and their controls were quite large. Their control was about 748, 504 patients. And they wanted to see those who had COVID and those who did not have COVID, those who were vaccinated and unvaccinated. Essentially, they did find that in the unvaccinated group, there was a higher incidence of post-COVID condition, definitely in the pre-Delta era, as you can see right here, per 100 patients, compared to here, when you see in the Delta era and the Omicron era, and the vaccinated group, it is much lower. So the incidence here is like 10.42. The incidence here is 9.51 per 100 patients, and this one was about 7.76 compared to the vaccinated group, which was about 5.34 here, and then the vaccinated group of 3.50. So some of this is just the virulence, the fact that the virus has changed. It's not causing as much long COVID symptoms. So we do see that it has reduced, but still that vaccines provide quite a significant percentage of reduction in the long COVID symptoms. And their decomposition analysis showed that the cumulative incidence of task reduction was about 28.11%. And some of them was related to the changes in the virus, the pathogenicity of the virus, but also the temporal effects that the vaccination can actually help reduce the long COVID or post-COVID condition by 71.8%, which is big. So the picture here this is a famous picture in BBC that was published in, I believe, in like 2022 of this Amazon indigenous man carrying his father 6 hours on his back to a local Brazilian center to get him the COVID vaccine and come back. Each way took him 6 hours. So that shows to you that, it's important to protect our population, get vaccinated. Some resources that we give our patients, long COVID for kids, COVID survivor corps. And learnings from our past clinic is that we're still, patients are still struggling several years after having the COVID infection, and patient-centered care remains the key in exploring what matters to the patient. Interdisciplinary approach is important. Chronic diseases should be managed in addition to managing the post-COVID condition and promoting vaccination. Another picture depiction. Thank you. Sorry. Took a long time.
Yeah, no. It's very. I love the fact that it's hands-on, real-world experiences that you have. That I think often many of the clinicians who are on the sessions are trying to collaborate with others to try to determine what medications work, what doesn't work, and which patients to try these various interventions with. I did put a couple of questions that I had on the chat. I was gonna ask the other individuals to put in also questions on the chat that we could discuss later. I was just gonna go over just a quick uh, a couple slides to talk about long COVID treatments and why it's so difficult and why we still haven't gotten any guidelines or treatments, at least promising treatments in long COVID. And hopefully with some of the kind of slides that one of our colleagues has done at Case Western, it becomes more clearer for individuals to understand why it's so difficult to do trials, and also why it's so difficult to get something going in terms of long COVID. So next slide. Uh, uh, and this is just an update on long COVID therapeutics by Ego Photocone from Case Western and one of the colleagues, and he was on ID Week, and he had presented these slides. So all these slides are actually, majority of the slides are his, and I'm just kind of summarizing what he had presented at the ID Week in terms of why it's so difficult to get clinical trials up and running for long COVID, and why we're not seeing at least some signal from some of the interventions that you mentioned, as well as other interventions that other people have tried before. So next slide. So the challenges that we face are that there aren't any uniform definition in terms of long COVID. And although we do have various, the National Academy of Sciences, we have the WHO and CDC guidelines in terms of definition, there isn't um, a ideal definition. It's rather heterogeneous, and so therefore it could become very hard to pinpoint one aspect of the disease condition to target, and also to find whether or not someone has improvements with. The trajectory of diseases are often variable. It's not all one size fits all. People can get better on their own. And one of the questions I asked Abby was, could the person who had the cortisol improvements with cortisol, was it just because the patient was already getting better? Could this just be a recovery from a disease process? So oftentimes people will think, is this an ongoing disease, or are we just recovering from the acute onset of disease from acute COVID? And I think it's still unclear, but it seems like people are suffering from a prolonged disease process rather than something that's, started with long COVID and people are just recovering. And the mechanisms of disease are pretty understood, and what are the targets? And there are multiple targets. Even our group has talked about monocytes, there's neutrophils, T cell, and there's a whole host of immune dysregulation that occurs that results in what we think causes long COVID, but we're not sure. The next slide. Um, in multiple the viral entities have resulted in variable long COVID-like symptoms. We've seen it with HIV, we've seen it with multiple disease, Zika and so forth, in terms of viral diseases that result in long COVID-like syndromes. Long COVID just happens to be that just more people are suffering from long COVID, and that hence the reason why we have much more of a concern in terms of the morbidity and mortality that might be going on in our community. And so there are some challenges. You could see that in terms of uh, uh, the challenges of these biomarkers. You could see multiple symptoms. You could see that people with shortness of breath, and then people who actually have uh, 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 more of a neurologic symptoms. And in some of those biomarkers that Abby had mentioned, from fibrinogen to VCAM, SCAM, which are um, vascular, endothelial, epithelial markers, can be seen on the left lower corner. And you could see that all of them, if you look at the Venn diagram, CRP is kind of like the central one, which has been found to be somewhat helpful in long COVID. But you'll see that there's IL-6, which is on the upper side in terms of being also a biomarker. But when you look on the right-hand side, you could see that there are possible mechanisms of viral persistence, lingering viral particles, and you could see some of the limitations, often with immune dysregulation, reactivations of latent pathogens, clotting, autonomic dysfunction, microbiome. And all of these things have been speculated as a mechanism of long COVID, but not everyone with long COVID will have abnormalities in these potential mechanisms. So next slide. And so without any clear uniform definition, there really is no clear biology targets, no defined approaches for monitoring the disease, and there's no defined approach to monitoring the improvements in or resolution, and hence the reason on the right-hand side, I don't know if the slides are bigger, but on the right-hand side of the it will show that the FDA hasn't really had any FDA approval for long COVID. And so the next slide, you could see, Melissa, is it me or is my slides the wording bigger, or does everyone also see that it's normal sized? Maybe it's me, only me. But these are the various interventions tried for the treatment of long COVID. As you could see, that there's a list of intervention trials: Paxlovid, naltrexone, and NAD, looking at mitochondrial damage, antihistamines with mast cell activation potentially, apixaban with potentially with problems within clotting and microclots. And then you could see various interventions, various citizenab, which Abby also mentioned as a treatment that the patient received acutely for acute COVID, but have also been looked at recently. Recall that number 19, varicitinib, is a JAK inhibitor. And I think I have one slide that shows that we're trying it in terms of improvements in neurologic as well as cardiovascular and pulmonary complications with long COVID. And then for number 20, GLP-1 agonists are really the hot topic now. It seems like everything seems to be improved with GLP-1s, from obesity to anti-inflammatory to even long COVID. So next slide. And so just that there are various trials, Paxlovid, that Abby mentioned. I'm not going to discuss this. I think she did a wonderful job on talking about Paxlovid and its potential. So far, to my understanding, various trials from Europe as well as UCSF and the Stop Pask, as Abby mentioned, on the Stanford trials. None of the trials in total, in looking at everything, had any signal of improvement. But the UCSF trial, when they looked at more of uh, uh, more subjectively, they found that a subgroup of 10% of people did have some improvements with Paxlovid. And so there are some people who do benefit from antivirals, but so far as a group in total, there is not a collective benefit. So next slide. Um, and this is the berry in terms of that's is a JAK inhibitor, and you could see that there are various groups that are looking at reversing some of the complications of long COVID. This trial, Reverse LC, looks at berry in terms of neurologic and cardiopulmonary symptoms with long COVID, and you can see that they do neurocognitive exercise capacity and biomarkers and viral reservoirs, which kind of indicate all of this. Next slide. This one is just, again, Abby also mentioned about how low-dose naltrexone, it is a glial cell modulator and a TLR4 agonist. And so it's a anti-neural inflammatory agent that some of our clients do seem to have improvements with, and I would probably advise most the clinicians to consider trials of this. It's not a fast-acting medication, but over time, there seems to be overall benefits, especially in people who have ME/CSF symptoms. Next slide. And this is just the GLP-1 in terms of being one of the hot topics in terms of GLP-1. And I've used it in, I think, at least 10 to 15 patients. And I've seen some moderate improvements in our clients. I don't know if it's if they lose the weight, that they feel more physically fit to be able to exercise. or if there's something else biologically going on. But it's promising. Next slide. And then the cellular ganglion block. And next slide. And then the spots with IVIG as well as ivabradine. You'll see on Abby's slide on the treat me, there were some improvements in terms of both of these agents in helping patients. And so it really depends on the POT symptoms and whether or not they get any improvements initially from both of these. But in terms of long COVID, the RECOVER trial, well, we have done both of these clinical trials, and hopefully they'll be out soon. Next slide. There's the Recover Energize that looks at pacing, which I think Abby also mentioned that seems to be probably the topmost benefit to patients. Next slide. And sleep is also important. You could see some of these items that the Recover Sleep is currently looking at. In next slide. So in regards to conclusions, there's a lot of work that needs to be done. The disease entity is not well defined, and we still don't know exact mechanism of the disease process in terms of long COVID. But we need to foster support in providing a supportive environment for our clients. I think Abby had that beautiful picture of the person who was torn and tormented initially and we need to, as providers, to help support our clients through their the disease state that they're kind of currently going through. They're suffering physically as well as mentally and psychologically, and so as clinicians, we have to do our most in trying to help them. And I think that's all my slides. So sorry for kind of going over. Abby, do you want to try to go over some of the questions that I asked?
Yeah, I wrote in there that stellate ganglion blocks for Kaiser was covered because we said it's a failed
Oh,
treatment for
yes.
others, and also depends on their specific plan coverage. And if procedures are covered within the Kaiser plan, then it would be, because there's so many different,
Mhm.
within the Kaiser HMO, you can get plans within it. And then the patient that was hospitalized with the adrenal insufficiency, she's still on hydrocortisone long term.
Oh, okay.
Um, we do have patients who have recovered from the adrenal insufficiency at 12 to 24 months who have not needed any more steroids, which was important. I think Paxlovid usage is really controversial. And the 15-day coverage is really hard to get. I think people can get by with ordering 5-day, 5-pack for 5-day treatment courses and follow them. And that's what we ended up doing, because every week we followed up at 5-day mark. Like, okay, how did you do? Metallic taste is a common complaint,
Mm.
as expected, and nausea. Um, yeah, it again,
Mm.
inconclusive evidence and really controversial. Yeah. Expensive drug now. So
Several thousand, right?
yeah.
I'm sorry for hogging some of the questions. The people in the chat, does anyone else have questions for Abby or myself?
I'm not seeing anything in the chat here. We did get a message from Adam Towell saying, thank you. This was a really interesting presentation. So kudos. So if nobody has any more questions, I'll go ahead and close it out. Thank you for our presenters for coming with us today. And then don't forget, our next COVID's echo session is on January 13th. And it's going to be covering transcranial magnetic stimulation and long COVID. So thank you so much and have a great rest of your day.